Basically, first-rate surgery is about bunions. Okay, whether they're 2 or 3 different types or the way we look at them from our side, most lay people are looking at their foot and saying, well, this is a bunion. Again, first-rate surgery, talking about bunions in particular. When we first meet, a couple of things we talk about in the individual patient is just doing a basic clinical evaluation, asking you questions about where and how it's become either discomforting or the change in function, pain, and or shoe wear problems. Radiographic evaluation is of a must. We look at the first and second metatarsals. We look at how the toe begins to turn, whether it rotates or not, where the sesamoids are. You'll see some radiographs later, and I'll kind of design or describe what those are and where they look to move as the development occurs. And then the other side is the surgical treatment. We'll talk about both conservative and surgery. Again, this is a presentation that's a little bit more ahead. Historical data on why and how these develop. 2 basic categories. One is we're either born with them, or 2, we develop them from something. Okay? So I ask a lot of patients that do present with bunion difficulties, who in the family has them? Somebody else has probably had them ahead of them. It's either mom, dad, grandparents, or great-grandparents, or you can look sideways, sisters or brothers, and then usually there's at least one foot or either both feet that can develop. Second is the acquired side. So you can have an injury to a tendon, you can break a bone, you can tear tendons or ligaments and then develop. So that's the acquired side. These are, again, the things we look at. You know, arthritic conditions are something we'll talk about in particular because those are some things that set up late with bunion development. Last, again, is occupation and job. That's more shoe-related functional activity, movement of the toe, if you're having a job that's required to walk a lot, etc. So we talk a little bit about that as well. My physical exam is pretty straightforward. Again, radiographic data, sitting down, finding out where your toe will move or where it won't move and how much it moves. Okay? Bunions usually develop more commonly in what's called a sagittal plane, which means up and down. So the more mobility, you see some patients that have flatter feet that develop it. You have some patients that do have a higher arch that can develop it as well. And then the transverse plane is the other one. Again, this is how the toe turns away from your body. So that just means how the toe moves towards the 5th toe instead of staying straight where it should. Okay? This is a picture of an exam, how we mobilize the first metatarsal in examination. If there's a elevated motion that puts you at a high risk of developing the bunion. You've heard of pronation and supination. Probably seen some things that talk about how the foot functions. This is basically one of the things that can lead to the development of a bunion is what's called pronation. So if your foot turns in more towards your belly button, flat. I'll exaggerate. If your knees kind of come together and your feet turn towards the middle, then you pronate. The opposite direction is called supinate. And we tend to see that mobility of the first bone, the first metatarsal behind your big toe, the more mobile it is, the more pronation you have, therefore the higher risk of development of a bunion. Okay? So to step back where we said congenital earlier, we talked about family history. You don't just develop a bunion. You develop how we walk. It's a genetic trait, how the flexibility and mobility of the muscles and tendons that we inherited from our family that leads to the development of the bunion. So you don't just develop a bunion like you do eye color. It takes time and it slowly changes over time. Okay? Another one is what we call met primus elevatus. Again, all of these are just big terms about how and when and where. Normal movement of the toe should be as high as these degrees. If there's any restriction, it can lead to different changes. And we talked about a couple of different types of bunions. One is medial, where you get the bump on the inside. Okay, on the inside of the foot, closer to the belly button. There's also one that's on top of the bone. And some will call that a dorsal bunion. It's a different term from the text. It's called hallux limitus, but it's still in some ways is determined a bunion. Okay. Physical exam, same things you would think that somebody would present with. Well, my toe's been turning in for a number of years. I'm starting to have more pain. The pain can happen on the bottom or the side of the toe, mostly on the inside. You start to see callousing under the second metatarsal typically, or even out towards the big toe where it rotates inward. The tendons can contracture, that's part of the development, and you have pain on the bottom or the bottom outside of the big toe. And then you have associated changes that are also in conjunction with those tendons is primarily the second toe starts to become involved. It's not always, but it does happen quite often. So you start to see how the second toe becomes more hammered in conjunction with the increased or further development of a bunion. And then last is we lose toe purchase. We lose the ability to toe off or put that big toe on the ground and walk off of our big toe because it keeps wanting to go to the side. And so there is a balance issue associated with the development of bunions. There you can see here just some very basic radiographs of a left is quite large. You can see how the hallux is probably almost dislocated on this side, and then the toe adjacent to it becomes involved where the second toe literally crosses over the big toe. Okay? This is, again, a unilateral case. We don't see it a lot in both, but in this particular instance, again, it's a unilateral. It's on his left foot. The right foot seems fine. X-rays, radiographic, and we talked about it earlier, making sure you don't have fractures or dislocations. The subluxation or movement of the toe to the lateral position, just like we had here, so it moves towards the fifth toe. It drags, again, the tendons with it. So everything moves to the lateral side. Everything goes that way. This is a reasonable picture to also talk about, well, what is the bunion? How does it develop? Is it soft tissue? Is it an overgrowth of bone? Or is it a metatarsal that moves? The last answer is correct. It's actually the physical movement of the first metatarsal towards your midline, towards your belly button. So it's not a bump that all of a sudden gets larger and larger. It's actually a movement of the metatarsal that creates the size or enhancement of the bump here. So his first metatarsal is actually moving over time, like your arm would, or like the clock would, or a hand on a clock would. Okay? When they first started doing surgery in bunions, they used to just go in and knock the bump off. Okay? Just take surgery and just go in and just cut that bump off right there. And that was before we really understood the entire dynamic of how the function of the bunion developed. And so reoccurrences started happening pretty regularly. So you see a lot of surgeries done back in the 50s and 60s and 70s that had a reoccurrence, a real high reoccurrence rate associated with it. Big words and angles we use to measure. Going back to that picture again, when the first metatarsal moves, there's an angle we measure between two bones, the first metatarsal and the second. And it literally will create, they're parallel, and it creates a V over time. All of us have it. Those of us that start to get 15 degrees or more start to have at least some level of pathology. That's usually the deciding degree of or angle of change. This is, again, a basic radiograph. You guys probably wouldn't see this. We do this behind the scenes of looking at x-rays and see where your angle of measurement are. So if I go back to this where normal is 15, we would measure, we would measure this angle, okay, to this angle between the first two metatarsals. Okay, that's what's called a metaductus angle. That's a different angle we look at. Second angle we look at is how far is the toe turned on the big toe joint. So right here. And that's how we measure it. Long axis to the big toe, very straightforward, but these are things we do behind the scenes to document angular changes. Same thing. We also look at cartilage. This is where we lead to the development or change of the articulation or the cartilage surface of the first metatarsal and the base of the big toe. So what I'll talk about is here. So we call them pasa and dasa. It's just some terms that are easy to remember. As you develop a change in the angle of the toe, the less contact, cartilage to cartilage, the more arthritis you tend to develop. Okay, so as this toe continues to move over here, they're not hugging anymore, are they? And cartilage likes to be hugged, so it'll die. And so that's how it begins to lead to the development of arthritis. The longer, the more excursion of that toe turns away from the first metatarsal. So this is an angle, and then this is another, another angle we measure on the base of the toe. Sesamoids, these are the little bones underneath the big toe joint, right here and right here. Everybody asks about those when they see x-rays. Sesamoids are normal, okay? They're the other most common, what's called sesamoid is a floating bone, intratendinous bone like your kneecap. So you have a kneecap and you have two sesamoids in both feet. Those are the pulley system or the strength which allow us to go up on our toes. So we have short flexors and long flexors that give us strength. That's why we're bipedal and we can walk off of our toes like that. So it gives us extra strength. They're also one of the things we evaluate as the development of the bunion occurs, they shift. Okay, so what happens is we just measure one of them on the far side, and as the bunion develops, it actually slides under the bone in these positions. So that's just another documentation tool for us to see how that goes. This is a basic concept of a joint capsule and different ways you can get into them. Okay. This was that old procedure I talked to you about. What did they do? They go open that incision, open that capsule, and just clean the bone off. Okay. Close the skin, no bunion there, right? That's what they thought. And then over time, all these tendons and things caused the function and moved the bone further out. Bunion came right back a few years later. So that's what this was called, the silver, the eminence resection. We don't do that anymore, and that's because of recurrence rate. So over time, that was the bump. So you're looking down the end of the toe. Over time, we've understood and become better and better at developing which procedure for which clinical presentation to prevent reoccurrence. Okay? So what happens is if you have what's called hallux interphalangeus angle, or HIA, out here, what you can do is you can work on the big toe, or you can do a little bit around the first metatarsal. And in this case, they did both. And again, it's based on all of these angular measurements that we do on how we determine what is going to work best to prevent the reoccurrence. So if we see that there's a minor bunion and we work on the first metatarsal down here, but the toe still has a little bit of a lateral drift, okay, from this angle, you can actually shift it over. That's kind of the demonstration of how it would shift over by working on that area. Okay, so you take that little piece of pie out, push down right there, and it moves the toe straighter. So the comparison is a little to the left, and this one's very straight. Anyways, I do want to show you this because it's the most widely used bunion correction anywhere. It's called an Austin. It's a V-type osteotomy. Okay, osteotomy means cut bone and shift it over. When you go back to the other procedure we talked about earlier, which was just move the bone, take it off, and they reoccurred, the reason it reoccurred is because they didn't adjust the angle, okay, by which the first metatarsal moved. This is how they reduce the angle, how we reduce the angle. You actually slide the bone over. This is what prevents reoccurrence rates in conjunction with capsulotendon balancing. So the metatarsal is actually shifted over. So if you could remember back to the radiographs where the V was much larger, we can shift that bone over to reduce that angle, and then your bunion disappears and the risk of reoccurrence goes away. Okay? So it's shifting towards the second toe. You can see it on that side on the far right. These are other procedures, measurements, how we do them, fixation techniques. That's from the side of the bone. Okay, so if I was able to grab this piece of the bone and pull it out towards you, you could change the angle from the top of the bone. All right, it's getting complex here. And that's basically how it's done. So from the side of the metatarsal, we shift that bone over to reduce the angle, and therefore no more large bump on the side of the metatarsal. the joint becomes congruous, and then we salvage the cartilage. So then the development of arthritis is usually a lesser risk. Okay? But these are demonstrations of how we fixate and how we do these procedures. And you say, well, what do you mean fusion? Fusion means taking the two bones of the joint and putting them together and putting some fixation in there like two screws and locking those joints together. If arthritis of the first metatarsal is profound and recreating a normal angle but increasing the motion of a joint by correcting a bunion increases motion on an arthritic joint, then you've not solved the problem. You've created a worse problem. So to reword that, if I correct a bunion that's arthritic and create more motion by doing the procedure, then you're going to have more pain from the arthritis that's there. So this is when that's used. So I have to stop the joint from moving. Exactly. So you restore the bunion by doing a fusion, but it stops the arthritic pain. Okay? They do make joint replacement surgeries for bunions, but bunion joint replacements are not widely used because the joint replacement can stress and fail. So if there's a bunion involved and you put an implant in there, you're putting stress on an implant to hold the toe straight, and the implant will fail eventually, then you've got to go back to surgery again. So bunions should be correct for their angular measurement, not for the arthritis. Okay? So to put an implant in there is the wrong choice for a bunion procedure. And first met fusions are very successful. And the right hands and the right guys that do them are highly successful for multiple reasons. Bunions, arthritis, joint problems, metatarsal transfer lesions, callousing, etc. You know, the first metatarsal is such a weight-bearing surface that when we walk, our weight comes out of the toe, just like this. Okay? So what we're able to do is actually recreate the weight-bearing line. If it's arthritic and you're not walking on the toe anyways because of pain, you're turning your foot. We tend to see stress fracturing and other pain this way. So a fusion is a very effective procedure.
What you're really doing is improving the balance.
Improving the balance, exactly. So if we had trauma in a young man or young athlete or young woman athlete, actually fusions are a choice to restore the joint and create a propulsive lever. So we have athletes that actually have fusions. You'll see guys in the NBA that are playing with fusions on them. The cause of the bunions, again, like we talked about, is knowing the cause. Okay, the first ray mobility, addressing the causative factor. If the joint's arthritic, if there's mobility, if the toes move more than it should be, if the sesamoids are out of position, all those things are the things that we look at, okay, from this side. Pre and post-op assessments, all of those things are very important. The clinical pathway, both the non-operative treatment and the operative treatment. Now let's talk about very basically. Non-operative is, I may see patients that come in and present with a bunion and say, I don't know what to do with it. It doesn't hurt. And a lot of times, I personally don't operate on a lot of non-painful bunions. The reason is because surgery can hurt. And if surgical outcome's not that good, then you could have pain chronically after we've done the surgery. So the deciding factor is usually there's some magic moment. It could be 3 weeks, 3 months, 6 months, that all of a sudden we've started to have more of a change. Pain when I'm walking barefooted, pain when I'm walking and just moving the toe, pain in shoe wear, I can't find comfort anywhere, and then there's a window of time where you say, I've finally got to do something about it. So there are, like I said, I call it a magic moment where you just go, all right, I can't tolerate this anymore, okay? The conservative side, ice bags and anti-inflammatory meds, spacers, so little dividers that we probably have all seen you put in between the toes to help straighten the toe mechanically, and then night splints are all potential short-term resolutions to relieve some of the symptoms that you're experiencing. But long-term, it's going to develop. It's a well-known progressive deformity. That's how it's written in the textbook. So it does progress over time. The other side's where they're painful, where you already click over that magic moment, they're painful and they're problematic. Then we start talking about some of the surgical approaches to deal with this. And then the recovery is such that in my office, it's usually, we do a procedure, you can ambulate through most of the procedures that we do in today's world. So you can walk. So you can have a surgery done and you can walk the next day, albeit it doesn't feel that great. 3 to 4 days later, it's feeling better, but you can walk through the whole process. Okay? So a lot of misconception from the old way. They used to put a cast up to your knee, put you in the hospital for this procedure, and you don't have to have any of that done. So you can go home, ambulate, walk, keep the bandage on. 2 weeks later, we take the stitches out. At a month, you're back to normal shoes. We start progressive range of motion after surgery all the way through the course. And swelling finally disappears around 8 to 10 weeks. But you've been walking through that entire process.
Like a boot?
A shoe or a boot, yes ma'am. Yeah. The left foot's better to have the problem in because you can still drive. Okay? So the left foot's easier than the right. So the right foot poses a problem because I won't let you drive because of the potential repair that we do. If you step on a brake and have to stop when somebody pulls in front of you, especially around here, you may break or knock loose some hardware that we have to use. Then we're back to the operating room, okay?
So how long is the driving restriction?
It's 4 weeks. So you're looking at a restriction for a month, okay? But the same recovery process is there. You just get a little more cabin fever. I want to change gears because there is one other side to this we would talk about, and that's hammer toes. It may be equally as in-depth, but I can at least go through the reference for you. All right, so hammer toes are the same way. Hammer toes are also congenital. Again, it's based on how we walk or how our gait changes. You may have a family member, grandparent, mother, father, etc., that start to develop a change in how these pulley systems work. That's the way the foot works, is all these pulley systems that change. So without getting too in-depth, if you take your hand and open your fingers like that, those muscles that are inside that spread your fingers that way are called intrinsic muscles. These are extrinsic because they come from your arm, your forearm. Extending this way, same thing, forearm, but this way are intrinsic. Intrinsic muscles are the stabilizers of the toes. Okay, so they're all in here and there are 3 layers of them, and they're very strong, but they're very small. And so they hold on to a thing called a sling right here. Okay, so if you were to grab the bottom of the toe like that, the tendons attach in that area on the sides and hold the sling, so when you stand, your toes stay flat. If those muscles weaken, the bottom muscle or the top muscle wins. And so up it goes. Okay? Or the other thing is they can pull transversely across where we saw earlier. So that's it in a nutshell. That's the basics of a hammer toes. It's going to develop over time. There are 3 basic theories about why this happens, but they're all based on muscle strength and muscle weakness. So the more active we are trying to walk and strengthen these muscles is really helpful. So that's the benefit of exercises, try and stay active and move. But if it's a congenital issue, it's going to happen anyways. So a lot of times where you saw earlier, a lot of the cases that we see, bunions, are associated about probably 40 to 50% of the time with second toe hammer toes. And again, that's why we do these discussions together. When you look at fixing toes and the reasons for these tendons are pulling and causing contractions, the only way to lengthen the tendons, to correct the toe without doing what are called tendon releases, are to actually take part of the joint out. Okay, it's going to sound kind of scary. When you take that joint out, what happens is if the toe's contracted and I pull this piece of bone out of my finger, the toe can straighten. And then if we put a wire down that toe, we can hold it straight and let it heal. The problem was the wire stuck out of the end of the toe about 3/4 of an inch, maybe a little less, and we'd bend it. We'd leave it there for 4 weeks. So you had to keep it covered, wear the shoe, and you look like Edward Scissorhands, right? So these wires hang out the end. Now wires are great. They were for that, and they're great for trauma, where you break a lot of bones and you need to put things back together like a puzzle. It's still going. So what I'm getting at is the development of new implants, like knee replacement or shoulder implants, have come along dramatically the past 8 years. Started with what's called a smart toe. Then it progressed to a pro toe, and then it progressed to what's called the neck extremity arthrodesis implant now, which is really good. Really, really good. But those implants have reduced the need for any external wires out of the toes. So patients are a lot happier about that. Okay? The same process occurs. We still have to go inside of there. You put the little implant on the inside, it stays. So the difference is, do we assess the patient for the need for a fusion to keep the toe stiff, or do what's called an arthroplasty, which lets the toe move again? Okay? The second toe, when it's associated with a bunion, or the second toe by itself, is always fused. There's a 4-year recurrence rate to the day almost. It'll come back. So we fuse those toes, to answer your question, to fix them. The second toes are fixed. The third toes, if they're severely contracted, we also fix. Okay? And what that means is they stay stiff. It goes back to that question you had earlier. Can we recreate a good toe purchase to increase your ability to feel the floor and ambulate better? Yes. I think I pretty much hit everything just in a few seconds. You can have a hammer toe from trauma, so acquired. So you can break the toe and the toe tears the ligament, disrupts the tendon, and then the development occurs. Okay? Compartment syndrome, so other traumas, car accidents that break bones in the upper leg, your fib area, your heel bone. Heel fractures very commonly are associated with the long-term, what we call sequela, or changes of the toes. So you can have heel bone fractures that cause hammer toe deformities. Strokes can cause hammer toe deformities. Remember I talked about the intrinsics and the extrinsics? Okay, so the intrinsic musculature and the outside, all these muscles, all of this is one little toe. It's crazy how much is going on around one little toe. Very complex issue. They stabilize, they flex, they extend. There's slips all over the place around these toes. Muscle, muscle, muscle. See, four more muscles and 3. So again, we trained with a hand surgeon that was from UCLA when I was in Florida, and the complexity is very similar to the hand. They pay a little closer attention. This is going to sound funny. They pay a little closer attention to the nerves because our tactile sensations in our hands are so important. He was very, very particular about that. But we did, the hands and the feet are very similar with all the musculature, lumbricals and everything. These are the 3 theories we talked about, how muscles weaken. Pronated foot is one of the most common, same thing for a bunion. Shoe types, orthotics, that kind of stuff can help. Surgical management we talked about here, and it really boils down to 2 procedures. Do you fuse that joint right here in the first knuckle of your finger, or do you take it out and let it still have motion? So 2 basic concepts. Okay. The one uses the implant that permanently holds the toe straight. The other may be a temporary wire still. Okay, so patients still don't like that option. Okay, same thing. There are some cases right here. Flexor tenotomy is very, very efficient. If we can do 1 or 2 toes. So if you have a contracture of a toe and we can grab that toe and straighten it. Okay, you can straighten it with your finger all the way. You let it go and it curls up, or you stand and it curls up. You can do a lesser procedure called a flexor tenotomy. That just means release the tight rubber band that's keeping your toe curled down. Okay? So every time you do that, if it recoils, you can go under where it attaches and release the little tendon, the toe straightens right out. So you stand in it. So certain indications we use this for are distal pain, a distal clavi, which is a really painful skin condition on the tip of the toe, or diabetics that have ulcers on the tips of their toes. Okay, so we can release that tendon, the toe will straighten out, and the ulcer will heal in a very rapid period of time. So what we started seeing in bunions and hammer toes, again, just like bunions that were done many, many years ago, patients have seen them reoccur. Hammer toes, they used to do the arthroplasty, which means remove that bone and put a wire in temporarily, and then pull the wire out. Okay? It did not fuse the two bones in that toe. So what happens, there's a flexibility there. You can still move it and you can still function and still do those things. But what they started seeing is around the 4th year, the tendon took advantage of that space again and just did the same thing that it did the first time.
You're just not doing that anymore, right?
We're not in the second toes.
Okay.
Absolutely, I will not do an arthroplasty on the second toe because 4 years later you're going to come back and say, why'd you do that? Okay. Conservative care for hammer toes, like we talked about bunions, I'll go conservative. Same things. They're splinting. It's hard. It's really difficult to do conservative care in the toes because there's just a dorsal splint. It goes over your toe and you have to slide it on and pull it down. Now, if you can keep doing that for 20 years, that's okay. But eventually you'll get tired of doing it most of the time. Questions of pain, okay, discomfort, angular changes. Is it going to cause a problem? Do we think it's going to cause pain in the future, etc.? You can go back into an area as long as the bone wasn't, as long as too much bone wasn't removed on the arthroplasty. The nice thing about these implants is they can create length. Some of them can create length. So if we had to do that, yes, you could go back and actually fuse that toe and straighten the situation out without having to theoretically add bone to your toe. The implant could make up the distance. Again, different docs like different procedures because they were either trained that way. Okay, so some guys were trained in a certain way that maybe they did bunions more in the rear section, causing more non-weight bearing. Others more distal, where you can weight bear more bunions. Others like the fusions. Okay, so there are lots of different things, and that's the beauty of second opinions. I like fusions. I like distal first metatarsal osteotomies. 95% of my cases get them so you can walk, so you can get up and go to the bathroom without having to worry about crutches. Okay, and we can, and that's why you see what some guys say, get a radiograph and have a picture, a measurement, have it looked by another physician.
Same for hammer toes if it's the right foot?
Yes.
With
Yes. I'm telling you, it's wonderful being a foot doctor. It is.
And I'm gonna, I know
Yep.
that you're gonna need to get back to office and continue the room.
Yeah.
I just wanna thank you so much for coming out. That was awesome.
All right. Thank you, guys.